Thank you very much, Al. Thank you very much, Al. I'm glad to be here this morning. I'm from Boston University, and this is a really important conversation in thinking about and understanding some of the challenges and assets of working in rural public health. It's so important for us to understand the various populations that we have in Massachusetts and throughout the country. So today I'm joined by 5 colleagues who are going to help us understand, so what's unique about rural public health? What are some of the assets about rural public health? What are some of the challenges around rural public health? And perhaps most importantly, I want to ask the question, if you had a chance to talk to the legislators, to talk to the governor, to talk to the commissioner of public health, what would you tell that person about rural public health? I have 5 colleagues, and I'm going to ask them to introduce themselves. But let me say their names first. Jane Smith, Marina Lent, Randy Crozier, Camille Griffin, and Laura Kittredge. And I'm going to ask each one to introduce themselves, to tell us just a snippet about who they are and about the setting that they're in. So you'll get a sense about the diversity of settings that we are talking about today. Jane, would you start this morning?
Yes, good morning, and thank you all for being here. So my name is Jane Smith, and I live in Sheffield, which is in the very southwest corner of Massachusetts, so in Berkshire County. And I'm the health agent for 2 towns. One is the town of Alford, which has 486 people. And then I'm also the health agent for Sandusfield, which has doubled that at 986 at the last census. And so also, I am part of the Public Health Excellence Southern Berkshire Public Health Collaborative. And so we're trying to build 12 towns in South County and build the public health system down here. So I'm also have a beef farm and we sell honey. So a lot of things going on here. Thank you.
Thank you. A bee farm. We could just stop this whole conversation and just talk about bees, but okay, we won't. Camille.
Thank you all for joining us. My name is Camille Griffin. I am the health director for the town of Webster, but primarily here today because I'm also the health agent for the town of Dudley. Dudley has a population of just under 12,000. Dudley is not designated as a rural community, but very much functions as one. I'm also here as a representative from the Massachusetts Environmental Health Association. And similar to Jane, Dudley is part of one of the Public Health Excellence grants for the South Central Mass Partnership for Public Health. And that is 6 communities all working together to try to achieve better public health in the community.
Thank you very much, Camille. Randy?
Hi, I'm Randy Crozier. Thank you all for joining today. I am the health director for the Cooperative Public Health Service Health District that's run out of the Franklin Regional Council of Governments in Greenfield. We serve 15 small towns. Proudly, I always like to say that we serve the smallest town on the mainland, which is the town of Monroe, which is around 120 residents. It is very rural, as I said, 15 towns doing about 320 square miles, serving roughly 15,000 people. Or I also say I serve 53 Board of Health members, 15 different boards of health. We have been a district for a little over 10 years now. We are a PHE as well. We are also hosting a training hub where we are responsible for training what I would call mostly the Valley area. So all of Franklin County, Hampshire County, a couple of towns in Hampden County. I think Laura has a couple of towns in Hampden County. And then we have 3 towns in Worcester County as well that we'll be working with through the training hub. So
Thank you, Randy.
thank you.
Marina?
Good morning, everybody. I am representing the 2nd smallest town, or probably actually not the 3rd smallest town, Aquina on Martha's Vineyard. And I came to public health straight out of Manhattan, came to the Vineyard, never looked back. We have the remoteness of a rural community. We are the largest town on the island of Martha's Vineyard is roughly 5,000. There are 6 towns, And we are also part of the Public Health Excellence area that includes Dukes County and Nantucket. So we're the islands shared service area.
Thank you very much, Marina. I want to hear more about that transition from Manhattan to Martha's Vineyard. I can't even imagine what that's like. Laura.
Hi, I'm Laura Kitross. I'm the Public Health Program Manager at Berkshire Regional Planning Commission. And some of the hats I wear as part of that job is Director of Berkshire County Boards of Health Association, which is kind of a support educational and professional organization that has served the boards of health in Berkshire County for 90 years or so, and also acts as the Public Health Emergency Preparedness Coalition for the FEP money funding and the deliverables associated with it. I am the director of the Berkshire Public Health Alliance, which has varied in size. I think we're about 23 or 24 communities at the moment in Berkshire County. We were formed after a year and a half of planning in 2011. So we were around for a long time when the Public Health Excellence Grant started, but we are also a public PHE grantee. And as Randy mentioned, we are also going to be housing one of the training hubs serving Berkshire County and parts of Hampden County. And I think that's good for now. Thank you.
Thanks, Laura, and thanks everybody for being here. I want to also invite our participants who are here to submit questions, and I want to ask you, just for my ease, if you will place those questions in the chat. It's easier for me to see chat than going back and forth between question and answer. So if you'll place your questions in the chat, that would actually be very helpful. I want to start a conversation in talking about what is unique about rural settings. As just about a little about me, I've only worked and lived in urban settings. I've visited the country, but the truth is I have not spent a lot of time there. So I need to be educated as well as helping others here to understand a little bit about, so what's unique about living and working in a rural setting? Who wants to start?
I can start with that, Harold.
Great, Jane.
So I think that one of the interesting things about being in a rural setting is we don't have some of the public infrastructure that larger cities do. So for instance, the town of Sandusfield only has less than 1,000 people, but they have tremendous septic issues and work to be done, as well as wells, a lot of beaver activity, right? And so you can't always collaborate the amount of population with the amount of work that goes along with that population. And the second thing is just really the access to people, right? So, we don't have the people that a larger area has. And so if you have a degree or education, you're able to find jobs that, and those people are kind of captured in those jobs in the nonprofit sector and the private sector. And so we don't always have access to, people who are looking to enter public health, which also makes it uniquely challenging. So those are a couple of things.
Okay, so some first in just thinking about the type of work, but then also who are the individuals that are able to work in the setting, largely because of issues around access. Who lives there, who's wanting to be in those settings? Marina, you want to continue?
Yeah, I have something to add on what makes rural areas unique and struck me very strongly when I got here is that people, that individuals in the community, the individuals not just in one capacity, this is my colleague, or this is the person who runs the store. You run into them everywhere. And so this is sort of on the positive and valuable side of working in a small community, makes it very different working experience. But again, as Jane said, the pool from which you draw for public health work is small by definition, and it's very difficult to really bring people in from outside. There are major difficulties with that. And so it really is a long-term commitment and a very sort of personal, almost intimate commitment that you make within a community to having somebody be taking on a role of responsibility like public health.
Marina, I want to come back a little later in our conversation and talk about the workforce, because both you and Jane have talked about the availability of individuals and what that means in terms of who's available to work. But I want to stay more with kind of the uniqueness around the setting. But could you please tell us what it was like to move from Manhattan and then move to Martha's Vineyard? And you said you never looked back. What stood out most for you when that happened?
The social side of things. People used to say, how can you take it? It's so quiet in the winter. It was socially wildly intense for me, because in Manhattan, you run through your day, you treat people as if they were cardboard cutouts. They don't exist because you need this shield around you. And here on the Vineyard, suddenly I knew people. I would nearly cause car crashes because I was trying to see where their car was in the parking lot. It's intensively social compared to the city, is my short answer to that. It's somebody described it as Cinderella's slipper. It either fits you or it doesn't. And when it fits you, it's like, why did it take me 40 years to understand that I belong in a small community? No,
Yeah.
I've lived in cities all around the world. And, like I said, never looked back. I belong here.
Thank you. Randy, I see that you were commiserating with Marina.
Well, I grew up in small towns and have always stayed in small towns. I think of Greenfield with 15,000 people as too big of a city. So I understand her wanting space. We have a colleague that works with us at FERCOG that will say, between me and Phoebe Walker, who most of you know, we know everybody in Franklin County. Our entire county only has 70,000 people in it. So if we don't know them, they probably only moved in yesterday. And I think that's a great benefit to rural public health. It's also can be a detriment when we're giving a housing order and telling somebody their house is, in squalor. It's often people in another way. And I've more than once been asked why my truck was at a certain address. And you kind of come up with, it's like the ambulance or the police, you have your own versions of HIPAA. So you need to just figure out the answer of why I was there without saying, hey, I got a complaint and the house is a mess.
So there are both pluses and minuses to actually having a small community and knowing everybody. One, you know people, but then also when there are difficulties, you know people as well.
Exactly.
Yeah. Laura.
Just as an aside, I'm also a New York City refugee into rural areas.
And did you have the same experience that Marina did?
A little bit different. I think I lived in more of a neighborhood in New York, so I definitely ran into people and had my community and so on. But I do agree with Randy that there's that 2 degrees of separation. It's not 6 degrees of separation out here. I can find anybody in the county within 1 or 2 degrees of separation. I've done it, and people are like, how did you find that person? I was like, I knew somebody would know them. Mm-hmm. I wanted to talk about distances because I don't think that's been mentioned yet. I agree with what my colleagues have all said, but I think that especially when you're trying to share services, which is really important when you have a limited workforce and small towns, they need to be able to serve multiple communities. But the distances, especially in winter, can be very long out here. Berkshire County covers 930 square miles. There's no major highways. It can take an hour and a half to get from where Jane is in Sheffield up to, say, Clarksburg on the Vermont border. And we only have one hospital system in the county. If you live in some place like Boston, you expect to be able to, if a hospital closes, there's one 5 blocks away. Out here, when we had a hospital close up in North Adams, it meant that people in some of the northern municipalities if they have an emergency of some sort, the volunteer fire department, who is the first people on the scene, and then they're intercepted by an ambulance, and then they're taken down to Pittsfield, depending on what the issue is. It could be 45 minutes before they're in a hospital. And that's if there's no snow, no ice, nothing. So it's more expensive to provide public health services in a rural area than it is in an urban area, which people don't expect. But it's just that the sheer distances make it, you can't be as efficient in how you do your inspections.
Laura, just to speak to that a little bit, this morning, my colleague has to go to a soil evaluation class because it got postponed from yesterday for rain. So I am sitting in one of my small town police stations where I have a little remote office because I had to cover for him on a field work this morning that's 45 minutes from my house, but only 15 minutes from here. So I came here, set up, drove the rest, did it, came back. So it's part of having these very large districts of small towns.
And to add to that, it's not just even like the physical distance, there's also a mental distance between towns. Like,
What does that mean?
well, so for instance, I live in Sheffield. In Sheffield, the best way that I can describe Sheffield is that in 1915, when they wanted to expand library services, the good people of Sheffield felt that was going to contribute to delinquency of youth because they should be out working in the fields, right? And then there's Great Barrington that's next to Sheffield, and every town has a very individual sense of self. And so getting not just boards of health, but select boards and other people to understand why outsiders are coming into their community and want to, and this was last week, quote unquote, pretend that we're kind of like Pittsfield or the big town of Lenox with things like online permitting or following the rules is really hard for some towns to accept.
So I was going to ask about the business of what it means for someone to come into the community and what it means to add an additional person. But before I ask that question, so hold on to that. Camille, we've talked about this idea of distance, both in terms of physical distance, but also in terms of mental distance as well. We've talked in terms of knowing people, and we've also talked in terms of the volume of the work that happens. Are there additional things that you would add, or maybe that you would comment on what's unique about working in a rural setting?
Absolutely. I think as similar to what all the colleagues have said so far, the close-knit community is definitely like everyone knows everyone. I'm relatively new to the town of Dudley. I've only been there for about 1.5 years, and I'm still establishing those relationships. So I am currently the outsider trying to come in and improve the community. I don't have that buy-in yet from the community. I don't have their trust. I very heavily rely on my board members who are, the face of the Board of Health. So there's definitely that challenge as well, because again, they are so close-knit that they don't necessarily trust outsiders coming in, especially from a regulatory standpoint. And something that Laura had mentioned as well was the cost of services. I think that public health services in rural communities is more costly. And then there's also the struggle because you have, a smaller population, a smaller income revenue stream for the community. So then you definitely have that challenge as well.
Someone wrote a note in the question and answer, which I think is really interesting, and it ends by saying, why is the idea of an outsider scary? That communities are of a certain size, they have a particular kind of look, but then you bring someone else in and maybe it's not the easiest adjustment to bring somebody in. So is there such thing as the outsider and the insider in your communities?
I certainly can speak to that. The outsiders can be viewed as they are going to step on mines in the minefield. They are going to fall through the thin ice time and time again. They are going to upset the very careful balance that people in a small community make who know each other. They know each other's weaknesses as well as, and the outsider can come in and sort of destabilize things and be manipulated because they are outsiders by somebody everybody knows, but that they're, or so there's this view that they will not only try to impose things on you, but that they will make a mess of a carefully balanced social structure that works for your community. Now, of course, we all know change is ongoing everywhere. And I think one of the dangers in a very small community is that you do feel that you know everybody. You think that you know everybody. Certainly on Martha's Vineyard, where we have this large influx of people coming who've come here for 40 years for vacations and they retire here. We may think we know everybody, but we may not actually know them if they don't buy in themselves, if they don't put in that time to get to know everybody, to be that type of community. We won't know about them. And they could be sitting there, you know, desperately needing something, and we won't know about it the way we know about our people. We know our people when they're in trouble.
You know, frankly, I don't know that there's a difference between what happens in urban settings and rural settings when it comes to this idea of outsiders. Because even in urban settings, we've always done it that way. This is the way we've done it for years. So why should we actually consider doing X kind of thing a little differently? Let me switch gears a little bit and talk then. So I've got a sense then about the kind of what rural life and what rural setting encompasses and kind of what's unique about the setting. Could you talk a little bit about a day in the life of? So is there a common day? Do you have Jane, you're saying, nah, no way. What are you thinking, Jane? There is no such thing as a common day.
No, I think that it's really hard to in these rural communities, and again, because it's fragmented, right? And so you're in different communities on different days, doing different things. So, you know, there's a lot of septic system stuff. And so, you know, if you have a new construction, which is rampant right now in our small towns, you know, you might be spending 8 hours looking at a hole, literally watching the water go down in a hole in an area that you might not even have internet access. And so there's that, you know, housing. I had someone follow me home from a contentious housing meeting. You know, I had to lose their tail. I mean, every day is just presents with it so many challenges around like trying to balance what needs to get done and what the immediate needs are. Like, for instance, witnessing things takes a lot of time, but it also is important that you're there to keep everyone honest.
Yeah.
So related to that, Jane, I think a big part of it also is our workforces are so small that we are not allowed to be specialists, and we have to be very diverse. So in cities, you may work for the health department and be in the food protection program, and your focus is purely on 590. We have to be the experts on, you know, 13, 14 codes. You don't know what's coming tomorrow. And, you know, I carry a book with me with every one of the codes constantly, as well as having them in my computer, because you can't always memorize each nuance of the word, but you are a specialist in all 15 of them or whatever at all times. So
Yeah, I want to emphasize what Randy's saying about that you need to know everything. And we all know that what you need to know for food protection is very different than, you know, if you're inspecting an apartment or if you're doing a perk test. And not only do we expect our workers out in rural areas to have all of this knowledge, but then we expect them to be willing to work, you know, 3 hours a week in a given town, because that's the amount of work that's in that town. So you want somebody with 5 or 6 different certifications and specialties and knowledge. And then you're like, yeah, I'll pay you $20 an hour for 3 hours a week.
Yes.
So it's very, very difficult to make sure that you have fully qualified people in the small rural towns unless somebody's, you know, serving multiple communities.
I want to come back to that moment in a moment, Laura, about the volume of the work that you have with the number of hours that individuals have to actually do that work, because it's a really important thing of how do we how do you maintain people as well as how do you get everything done. But I'd like to focus a little on, so what is the work? And are there some, and we've talked about uniquenesses in the rural settings, but I'm wondering about the major public health concerns that that happen in rural settings. Are there things that are unique? You already started by talking about septic systems and beavers. What else?
Well, I mean, housing, right? Adequate
Yeah.
housing is a huge thing. So, you know, in the Berkshires, it is, we have a lot of second homeowners, right? So it drives pricing up.
Yes.
And so housing and getting quality housing is very difficult for young people, for instance. And if it's substandard housing, which many of situations are substandard, well, then it becomes a matter of, you know, how far do they push it? How much do they advocate for themselves if it might mean that their place is condemned? And then where will they be? And apparently, you know, it's really a struggle for a lot of people to know whether or not to take their children out of like a lead-laden
Right.
house with mold, because being homeless seems more scary and worse for them. And then there's the situation of transportation. So people aren't as mobile, right? Because everything is so far away and we don't have a strong public infrastructure for transportation. And so people really do have a sense of self, in part because they can't afford, if they can't afford to go an hour and a half to go to work. And so it makes it really difficult.
And add on to that, 90% of our homes are 95 are owner occupied homes or second homes. It's not rental, it's not what. So often by the time it's been substandard for a multitude of years before we ever get involved. Because how often does somebody come into your private home and look at something? So it's usually in really, really poor shape before we can get in there and try to help somebody.
I worked for the town of Chilmark, 700 people for 14 years. I got 2 a few ridiculous ones, like, you know, a rat got in, but it was obviously a really well-kept home and somebody saw a mouse on the floor. Oh my goodness. But it has also happened to me that I've gotten a call and I've explained to the person what the sanitary code is, and they say, never mind, I never talked to you. Or we understand that people are trying to get by in creative ways, that some of which work and some of which don't. When the sewage builds up in the walls because you have 15 people in a 3-bedroom house, there's a problem. When people have, you know, have created carved off a little sort of in-law apartment type thing, and they're renting it out, there, you know, that's where the creativity of the code comes in. But also part of the question of the specialization to just, that is an extremely, one of those curse and a blessing things. I've often felt selfish for being able to be this much of a generalist. I love knowing all about, you know, having to know about everything. I would not thrive if I was narrowly focused on a single code and doing that all the time. No, it's unpredictable. And in a small community, you may not, you know, there's some things you won't see, like we won't open a dry cleaner in Aquinnah, but just about everything else, you'll see it. You just won't see it as often as they do in a large community. But that also means that the experience you need to deal with it really competently is harder to come by. You know, I worked on an ambulance and I went to Cambridge for a year. And just because I knew I wouldn't see these things. It would take me 15 years on the ambulance on Martha's Vineyard to see the things that I could see in 5 months in Cambridge. So that specialization thing is a blessing and a curse, and it's a strength and a weakness. But it is very much on the part of, it's more expensive in the small community. And
You know, one of the things that we tell people when we are interested in trying to encourage people to come into governmental public health is the variety. And that it is one of the wonderful things about the work that we get a chance to do, that no day is like any other day, that there are a number of things that we'll see, but there is no such thing as a typical kind of day. And certainly this idea of being a generalist is an important part of the work that you're doing. So you've talked about 3 important areas, and I'm wondering if there are others. You've talked about the beaver, you talked about septic systems, talked about housing as being a major concern. Are there other major public health concerns that you would experience?
Addiction. I mean,
Is that unique?
no, it is not unique, but it is obviously, it is huge. It is not built into our positions to be able to address it. There are some things that are unique. For example, in a relentlessly seasonal community like Martha's Vineyard, the summer is all systems go 15 hours a day. A large part of the population is in the trades. We are the village that serves the big mansion of the dukes and the princes. We are the village down there that's doing the farming and keeper of the hounds and all that. That's us. And so when you're working 15 hours a day in the summertime and you injure yourself, you don't stop because you don't have sick leave. You may not have health care. You may have access to pain relief, pain drugs, so that you can keep working. Because if you don't keep working, you're not making it through the winter. There's that aspect of addiction. So of course, the pain medication, the opioid pain medications is a big deal and is exacerbated by this injury and healthcare profile. Alcohol is still king. Let's never forget alcohol. And I feel really like I cannot, as a public health person, I cannot put the majority of my effort into what's killing the majority of our people. And I sit there watching water drip through a septic system perk hole.
So addiction is really related in some instances to survival. The idea of that you've got to take care of yourself in order to be able to continue to exist and to exist. And I suspect I don't know what it means to live in a seasonal community where most people leave and you have a small number of people who were there and then you swell to a larger number. And it sounds like that may be common among some of you. You've talked about second homes. So that would suggest that people are not there all the time. Is that what you mean?
And that doesn't show up in the census, right? So everything is like cost per capita, even with the most recent assessment, was based off of census data. Well, that doesn't apply for a town like Lenox that their population
Marlboro,
is. Yeah. And then along the idea of substance use and substance misuse is like, in South County, we don't have any supportive housing, for instance, for someone in recovery. So we don't have it. So either they have to go to Pittsfield and travel a half an hour to 45 minutes to where they live and work, or I guess that would be working, or they're just at risk because we don't have options. We don't have enough housing to have housing first models. That is a special thing that's, I think, unique to rural counties, as well as, for instance, we have a lot of venues that are very isolated. New Marlboro is a great example. If you were at a wedding in New Marlboro, not only would the guests not have cell service, also it might take a half an hour for the ambulance to get there. And so it's really important for public health is in a unique position to help, like Berkshire Regional has a normalizing naloxone campaign, getting naloxone in the hands of the actual establishments of where there are these large venues that are kind of higher risk venues. And that's something that doesn't show up as something that we would necessarily have to do, but it is something that will save lives in a different way than maybe a more urban setting where you would have emergency responders that could get there much quicker.
Yeah, and I just want to make sure that people know, if they don't, because why would you, that, Berkshire County has one of the highest opioid overdose rates in the state, and it's not good when you compare it to other areas as well. We have a huge problem out here. You think of it as, addiction and substance use as an urban problem, but it's a huge, huge problem in rural areas as well. I want to go back to kind of the more traditional public health services too, though I think Marina makes a really good point in bringing these kinds of things up, which, even more than many parts of the state, we're unequipped as local public health boards of health and local public health departments to handle, because we're so busy trying to handle, everything else with limited staff. But we do come up with some more regional solutions. But food production is big out here. You wouldn't think it because it's a small population. But again, everybody knows the Berkshires as a summer destination, and we have a lot of both second homeowners and people who come in for a weekend or a week or a couple of weeks. So there's a lot of restaurants, and that food protection needs to be done. Great Barrington, which Jane mentioned, has hundreds of food establishments that have to be inspected every year. It's a town of 8,000 people. Summer camps, also very large out here, and enormous amount of work to work with a summer camp and get them operated, all the policies and procedures and making sure that they're following the code. But there's a lot of large residential summer camps out here that people from all over the country, certainly all over the Northeast, send their children to. So those are two big areas that I didn't hear mentioned by.
The thing that I think that I'm hearing more is that, so if you think about your work and you think about the work that happens in urban settings, many times your work is the same. You are doing some of the same kinds of issues. You are needing to, well, we don't deal with beaver in Dorchester. However, but you are dealing.
Except, Harold, that Title V is about 60% of what we do out here.
Yeah.
60 to 70%, and you don't do that in the urban areas. So.
Yeah, well, but I want you to know I have rats in my neighborhood. So, but let me not talk about that. So, but you have some of those regulatory kinds of things you need to deal with, and thinking about housing and food protection and the like. But you also have a range of community health concerns, looking at issues around substance use disorder, and that it. And as you've mentioned, Laura, you've got a very high rate of substance use disorder in your area. So in some ways, some things are the same, but the thing that seems to be unique about it is how you deal with it. That you have long distances that you've got to travel from one place to the next. You have fewer people who are engaged in doing the work. There may be some other things that are unique about needing to manage those kinds of things. And I want to turn our attention a little bit to talking about the structure of the settings that you're in, because you said, Laura, I think it was you who said you sometimes have to hire these people who are generalists, and you give them they need to know a lot of things, but they have to do it all in 3 hours. Could you talk a little bit about the kind of structures that you work under, and what's positive about that, and maybe what's challenging about that as well?
Sure. So again, there's just, in a town of 800 people, nothing happens all that often. They don't need somebody there 5 days a week or even one full day a week, but they do need somebody who can handle anything that might happen to come up. So, it just becomes, we expect people to be highly educated and certified, but then we can't offer them full-time work with benefits. And the only way to get around that is through sharing people, either informally or formally, or something in between the rural communities. Massachusetts is unique, as you and I well know, at the 351 cities and towns and 351 local boards of health. The quote that I always say is that California, which has many times our population, has 61 boards of health. Massachusetts has 351. We have something like 11% of all the boards of health in the United States. So it's kind of a crazy way to run a local public health system, but it's the system we've got, and, you know, home rule isn't going away anytime soon. So we have to figure out a way to kind of circumvent that for local public health, because people need 35 or 40 hours a week. They need benefits. They need to get paid a decent wage. So we have to figure out how can we put together a bunch of these 800,000, 5,000 town resident towns into a system where one person can get full-time work and not kill themselves doing it in the process.
Well,
Because as
related
Randy
to
said,
that, Laura,
reporting to
is-
53 boards of health members is, and they're all characters and they all have their own ideas about what you should be doing. And it's that many nights away from your family and having dinner at home, you know, to expect somebody to go to 7, 8, 10 boards of health meetings in every month is not realistic either. So it's a difficult problem.
I've been to 6 Board of Health meetings since last Wednesday. And only one of them was during the day. But related to what you were saying, Laura,
3 in one night
Yeah.
in the
Yeah.
snow.
Yeah.
That's still my
related
record.
to what you were just saying is, you know, only having somebody available 3 hours a week in some small town is all they need sometimes. Exactly. Oh, but wait a minute, the code says they get a certain complaint, they have to respond within 24 hours. No, it's Wednesday and my day is Tuesday and I'm not there again until Tuesday. Isn't really, when there's an emergency, that doesn't help. You get a call that somebody's septic is running down the front lawn into the neighbors. Well, okay, well, it's Wednesday and I work on Tuesday. I'll come look at it. Again, not an answer. So, you know, regionalization, in my opinion, is huge. I mean, I worked a lot of years to get a district formed.
Yeah.
We need
I
it.
think
in these
that
small
the
towns.
danger of regional, like not of what we're gonna have to do in rural areas though, is try to figure out how to have share somebody, right? And I think an agent or director is an ideal thing for interaction with the board. But you know, if you have someone who's really good at septic inspections and they go and do all your septic inspections, but they're not the one that's approving the plan for the septic, or that they're not the one that goes to the meeting, sometimes the boards take on and understand things in a way that's inappropriate and approve things that never should have gotten approved. Same thing goes with towns who pay a outside contractor for food inspections, for instance. You know, if it's an independent person, that person might not have any way of getting paid to go to training. So even if they can get paid to go to the training, the actual cost of the training, who's going to cover the time? And so what does that create? That creates a worker who is not getting the professional development that they need and the support from their peers because there's no mechanism to pay them. So I think that a lot of the work that we're going to have to do in rural areas is figure out how to allow people through shared services to specialize without sacrificing having someone there that understands the rules and can bring it in to make sure that there's appropriate decisions being made in these smaller communities.
And you're exactly right, Jane. And I think, you know, Laura's been involved with regionalization as I have. A lot of it is very difficult. I'd liken it back to the newcomers. It's a new way. And people are afraid of it. It takes a long time and you have a lot of buy-in that needs to be. And much like, you know, no 2 boards of health are alike, no 2 towns are alike. And so, you know, what works for, I mean, I could give you our model and tell you it's great. Okay, well, it works for us for most of our towns. It may not work for the next group of towns next door. And you know, theirs may be more right for them. But it's important and it's a lot of work to hold a regionalization thing together. I had a great discussion with a Board of Health member yesterday because he's worried about Laura's example of the 61 boards of health in California. I happen to use the one that says there's more boards of health in Massachusetts than there is in California and Texas combined. And this guy was really worried about home rule. And I said, there's a lot of things that towns don't do. I bet almost probably all of us on this call have a driver's license. It was not issued by our town. We register our vehicles, again, not by our town. So there's things that can happen, but it's a change of thought. And it is, the newcomers are changing things, and it does happen. And
So
Yeah.
this idea of doing regional work is one way to actually address some of the complications that you were talking about. Laura, you're trying to say something a second ago.
I was, but I want to respond to what you just said, the regionalization. I think in rural areas, in some ways, although there's the strong town sense of town, as Jane talked about, we're used to having to work together because you can't get anything done in a rural area if you don't all work together. So to some extent, we're used to working together and we can do that. I wanted to go back to Jane's point, though, about training, and that if you're getting paid by the hour, you don't necessarily get that training. And I want to really urge everybody on this call to be thinking about the workforce standards that DPH is coming out with. I think there's both a fear in rural areas that we'll never get anybody who meets those workforce credentials, even though we do have people who meet them. But I also think it's a way to get things done in rural areas, because if the towns have to hire somebody who has the credentials, they'll find a way to do that. And we have an issue out here, at least, where you have Board of Health members who are doing the inspections because the town doesn't want to spend any money. And so you get people who get elected to a Board of Health who's never done anything like this, and suddenly they're the ones that are doing the inspections and enforcing the codes in the town.
They're the
And
generals
they're the
that's an
ones that
extra.
you appeal to. So
Right.
they're the ones that write the order, and then you appeal the order to the same people or persons.
Well, I think at the beginning of this, Dr. Cox asked what we would do if we had an opportunity to talk to the legislature. One
Yeah.
of the things I would advocate strongly for is I would love to see it said, basically that a seated member of a Board of Health shall not work as an agent for that Board of Health,
I would
either
love
paid
that.
or unpaid,
Yes.
period.
Yeah.
And
Agreed.
it is also, though, as we do this training and find people who actually can do it, and that we can share services so that we can benefit these people so they stick around and have a sense that they have a real commitment to the place instead of filling in while they're raising a kid or something. We've got to bring the boards along. What I see as a danger with our regionalization efforts, our shared services, and with contracting generally, we've always had public nursing contracts or something, is that then the governing structures, and people have alluded to this, that the decision makers sort of say, oh, that part's covered, I don't need to know about that. And then you just become, an administrator of contracts, and you lose that generalist overview, but also that you actually know what those decisions are about because you're dependent on your contractor. And that is a part of town identity, for example, that I think really must not get lost. We have to keep them on board, not to use a pun, but we have to bring our boards along. Us agents have been working intensively with the state on shared services, and we've had discussions that we have not been always able to bring our boards with us. And the boards hold the authority, and they are the elected, they're responsible to their electorates, but they hold the authority of public health. And if we let this go too far apart, there's going to come that moment when the boards say, whoa, I ain't voting for that. You're done.
So
And
I'm sorry.
Yeah.
Please continue, Marina.
I just want to say that if we don't find a way to bring them along without requiring things they cannot do as volunteers, as elected volunteers, some of whom have full-time careers of their own, we are going to come up against a bit of a brick wall in Massachusetts.
So I really appreciate what you're saying about what it means to change, what it means to engage in a different model of services. Laura and I worked for a long time in kind of thinking about this on a committee that we were on, and it sounds like more conversation is definitely needed with the folks at DPH. And I want to jump to that in just a sec, but I want to go back to a couple of questions that were raised in our chat from our participants, and these really have to do more with community health kinds of concerns. So someone wanted to return back to our earlier conversation about substance use disorder and talk a little bit more about what might be some of the issues behind that. And the questioner says, do rural area experts think that the driving force associated with substance use disorder is job-related injury?
Since I raised that as one avenue towards particularly opioid use, I'd have to say no. That is an oversimplification. That is one avenue. There are multiple ones. There are sort of kids on a trajectory. There's that difficult in between time after graduating high school and before becoming settled in work in a place like this, where you do have you have that seasonality, and you have that the kids are trying to find their way. There are many drivers of addiction, and it is obviously a societal, national issue, and a deep in our culture and way of dealing with things. It is extremely complex. It is also very, very local, addressing it locally. And in the last 2.5 years, we've developed one of these hub table models where you bring different disciplines to one meeting to address acute hazardous situations. And you've got your pastor sitting next to your police chief, sitting next to your SUD recovery coach, sitting next to, whatever. So it is both a much broader issue of our country as a whole, and it needs to be addressed locally as well. All the different vectors need to be recognized, and definitely workforce injury is one, because it's so easy. The pressures are so high, the stresses and stress of, all kinds of stresses, using substances to relieve stress is a broader picture in that sense.
Yeah, I think certainly this idea that it's a complicated issue that's caused by many, many different factors, and that any number of different people will result in having substance use disorder and substance use concerns coming from a number of different places. And the second question was about, could someone talk about domestic violence in rural areas?
Well,
I mean,
little
I
towns
think-
don't have that. Don't you know that?
I
All of
said-
our small towns don't have any of that.
Oh, you don't have any problems? No.
No,
Okay.
never.
And we should
think-
all just come to them. Okay, right.
What I would say in, reality is much like a lot of other things, a lot of it's hidden. Because, it's different when, I think the last time you and I spoke, you talked about seeing 400 housing units outside your window. Most of my towns don't have 400 housing units in them. I think a good half of them don't even have 400 residents. If I'm living on a 100-acre piece of land, I can hide a lot of things.
Yeah.
Including what goes on at home.
And I think that the small population and the fact that everyone does know each other actually is not a protective factor when you talk about domestic abuse. I think that we tend to keep things tighter because, your therapist might be on the same mahjong league as the wife of the police chief, or, there's so many other avenues of information and gossip, and that I think that people who are subject to domestic violence and are the victims of domestic violence, it's just a lot harder for them to have that anonymity, you know what I mean, to get the help that they need and be able to get to a safe place if that's what's needed. So without it being a community involved thing. And so, and I think that probably also is a driver of substance use, right? Is like, there's so much pressure to be who we are and how we fit into communities. I think a lot of times when people are having a hard time with there only being one medical record, for instance, in the whole county, where are you going to go if you're having a mental health crisis and you don't necessarily know who's going to be reading your medical record, because you also go to your physical therapist. And so I think that being small creates a situation where you hold on to your privacy a little bit more, because you just don't know, and you don't want people talking about you. It's unfortunate.
So privacy is important, and
And I would
privacy is a
also say
challenge. Yeah.
that the services just aren't as available. I mean,
Mhm.
as far as I know, we have one domestic violence shelter in the county. Everybody knows it. Everybody knows where it is. So there's no place you can go and be kind of hidden if you need to get away. And, you know, I think Jane's point about, you know, you may well know the person who does the intake at any given social service agency from somewhere else in your life. Their kid is in your school or whatever. I mean, that can happen anywhere, but it's more likely to happen in a rural area. So I just think the lack of services and especially the lack of anonymity in those services is also a factor.
Yeah,
I think
Camille,
that the lack of services is definitely a point that I was about to bring up as well. And then transportation to those services, because, you know, a lot of, you know, households may only have one vehicle. So how does someone actually, you know, access those shelters that are not close by?
so someone says, how will regionalization, this switches a little
I
bit.
want to respond to that. I just saw that one,
Yeah,
Harold.
yeah. So please, let's read the question.
So it says, how will regionalization benefit urban areas that are surrounded by smaller towns? The idea being that, you know, you've got it all handled and the smaller towns don't, so they'll bring you down. I'm paraphrasing. I don't
think that that's what that person said,
necessarily
but okay.
saying that's what
Right.
you're saying.
All right.
But I want to say that public health issues, this is kind of a truism, they don't stop at town borders. I mean, COVID being the perfect example. If the town next door doesn't have a public health nurse who was putting people into quarantine and isolation when COVID just started, they were coming to your town to the supermarkets. They were sending their kids to your school. They were coming to the physician's office in your town. So that's kind of infectious disease is the easy example. But if their septic system's polluting the groundwater or the reservoir that serves your town, even though you don't have a well, if their septic system's polluting the water that comes into your house, that's still a problem. If you go to eat in the restaurant in their town, you want to make sure that you're eating safely, and not only you, but your vulnerable family members, your children, your older people who are really trying to protect with food protection. So I just think that it's short-sighted to say that, and I'm not saying that, Lauren, whoever you are, I'm not saying that you said this. It's very short-sighted to think that we can be little oceans or little islands in the middle of the ocean and keep our residents protected while next door they're not protecting.
I'll go a little farther with that, Laura. And also, you know, in Franklin County, and I'm sure Berkshire County, you mentioned earlier, a lot of small towns where the Board of Health members are acting as their own agents. They don't have the expertise often. They don't have the training often. What they do have is some neighboring town that's a little more urban that has a paid health department, health staff, and they reach out and ask questions. So in some ways, regionalization helps the more urban areas because the city of Greenfield's taxpayers are not paying the Greenfield Health Department to help one of the small towns next door work through a problem.
So
because
let me
they are served by a health department.
Let me say some more about that. So I worked in Cambridge for a long time. Cambridge, 6 square miles, 2 hospitals, entirely different than the kind of communities that you're talking about. We have 2 hospitals plus I don't know how many community health centers there are in Cambridge with the 100,000 plus people that are in that particular community. Tiny, by Cambridge size, huge, tiny, but still some number of services. Regionalization would be incredibly important because even though I had a sizable, much larger staff than most communities, there weren't nearly enough. There were so many more issues that needed to be dealt with. And as we talk about these community health concerns, substance use disorder does not stop at the border. People cross homelessness does not stop at the border of Cambridge. Issues around men's health does not stop. It is so important to be able to work collaboratively across communities. And then mosquitoes also don't stop right at the border of Cambridge. So thinking about how we regionalize, how we work collaboratively with others around us would be so critically important. But the same challenges that you have are the same ones that people have in urban settings of thinking about how you do kind of cross border stuff. All right, so we have a new commissioner who's going to be starting with us, Dr. Robbie Goldstein. Dr. Goldstein is an infectious disease doc who is from Mass General, and he will start sometime in mid-April. Really excited to have him. Very grateful for the work that Commissioner Cook has done and Commissioner Burrell have done over this past period of time. But now we have a new person coming in. What do you want Dr. Goldstein to know?
I think I would start with a positive and say that it is a really positive time in public health in Massachusetts. We are finally getting the funding. I will point back to the blueprint and the credentialing that's going to be required, which will also include some Board of Health members. Speaking to Marina, I agree. I spend an enormous amount of time educating my Board of Health members. And I think go way back, your level of public health should not be determined by your zip code. And so, it's exciting, but I would want the commissioner to know that this is just the beginning. And I would encourage the commissioner to push hard to get the SAFE Act passed. It's great that there's 309 communities in Massachusetts working with the PHE, and we are signing on saying we're responsible for those credentialing. There's still a few towns missing here. Let's get them on board, make it, and codify it. Let's make this keep going. When these PHE grants end, does that mean none of us need credentials again and we can go back to the Board of Health of 1995?
Marina.
Definitely want to piggyback on what a unique time this is and how important it is for a commissioner of public health. There is no going back to 2019. There were some lessons of the pandemic years, not limited only to COVID. The whole moment of understanding in the broader society, many people already knew it only too well, about how inequity drives the disparities and how brutal and relentless those disparities have become. I am excited that Massachusetts, it's an accident of timing that Massachusetts started this whole blueprint process way before the pandemic. If we don't take advantage of what we learned during the pandemic, if we relax and say, let's go back to 2019, shame on us. And certainly as far as rural areas and the costs associated with it, as we were saying, it takes longer to go from one inspection to the next. It takes longer also because people spend a lot of time talking to each other in rural areas. But we need to do that. If you're stopped behind two pickup trucks that are, blocking both lanes because they're chatting, let it happen. This is what we do. But we need help to address those challenges of recruitment and retention. My position currently 15 hours a week and a hard stop at 19. I wonder why? Because of benefits. I am not independently wealthy. I am struggling now. I'm going to have to find pieces, and can I be somebody's animal inspector, please? And just try and make it
I got
work.
a couple of towns needing them if you don't mind the drive.
Yeah, actually, I think we've got a couple too.
I love animal inspector. It's all about infectious disease and yeah, I'm into it. But things like the additional training we need. Like I said, we will see everything in rural areas. We just won't see it very often. So our experience level is lower, but our need is higher because mutual aid will not get to us. we're in a climate change context. Let's not kid ourselves. You know, Hurricane Sandy bullseye on Martha's Vineyard is not out of the question and is when, not if. And we will be low on the triage list, and appropriately so, because you, Massachusetts, will try to save the greatest number of lives that you can with the available resources. You won't be sending people to Martha's Vineyard. So our capability to take care of ourselves, that's an investment. And we need that investment. We need programs in the high schools to make sure that we bring kids to public health, so we don't have that brain drain. All of these types of things, I have some ideas, and it is expensive, and I apologize for that, but I don't apologize for that, because we exist, and equity is a critical value in urban areas and in rural areas and everything in between. You know, between the two of us, or rural and urban, we have got to get this to be the priority, the equity and making a good public space for Massachusetts.
What else do we want to say to him? I'm sorry, Randy.
Marina, you just said what we do is expensive, and I agree with you, but I would also argue if we don't do it, it's a lot more expensive. Taking care of the problem that we try to stop is going to be more money.
There is that, you know, while we are a society that says we do not just let people die on the street, it will be more expensive to keep them from dying than not. You know, we've got to, if we have these values as a society, let's do it right. Let's do it right.
What else? What else we wanted the commissioner to know? Yeah,
I
Lauren.
would just very quickly ask that, you know, so in my 17 years of public health in Massachusetts, I've seen a bunch of different commissioners come through, and they've all been great in their own ways, but some have made an effort to get out to the communities, and some have mostly worked in Boston or from Boston. And I would just ask the commissioner to come out to the various parts, to come and see Martha's Vineyard, come and see Berkshire County, get to know the people who are out here, come up to Franklin County, go around with Randy, see what's going on. Because I think that's how you learn, and that's how you really understand what it's like on the ground for local public health.
So you want a commissioner who's going to be visible?
Not just visible, but actually present at times. It doesn't have to be all the time, but you know, I always think back to John Auerbach, who used to come out at least once a year and do those sessions. I forget what he used to call them, and actually sit and listen to what people said. I'm sure he hated it at times, but he did it. And I think it really made a difference, both in terms of how the population out here felt connected to Boston and to DPH in Boston. But I think it also affected how DPH saw the various parts of Massachusetts.
You know, I have to tell you, I don't think he hated it. I used to talk to John about, and I actually visited with him a couple of times in some of those communities, and he actually loved it. He liked getting outside of his office, and
people were so grateful that he came out here. I would hear about it for weeks afterwards. I can't believe the commissioner came all the way. I'm like, it's 2 hours. How hard was it really? But they were just so overwhelmed that he came out here.
Jane, I need to come back to something that you said during our prep meeting, and we cannot get away from this conversation without talking about this a little bit. You talked about this idea of Boston-centric policies, and said that sometimes we spend too much time trying to squeeze Boston into our little communities. Could you say a little bit more about that?
Well, I just think that communities like Boston have an idea of where the state of public health is. And I think I recounted a story of one of the towns that I work in. So there's only two that I'm the agent of. I actually, their health agent of 30 years passed away unexpectedly. Nice guy, community oriented. All of the files were in his truck and in various houses that he had around town. And so we are missing multiple years of plans and just documents. And I think, you know, I've been in other towns that helping them with their food inspection. They're like, we haven't been inspected in 11 years. And so I think that part of it is just understanding what the state and some of the towns, not all, just what they're dealing with. And so some of the policies that we're looking forward to, right? Standards, are really hard when a town has historically put $1,200 in for budget, for their budget for public health for the year, and also did not spend all 1,200. And so I think, you know, just understanding, and this goes back to what Laura has said with the commissioner, is just understanding the dichotomy of, you know, where public health is at different towns. Some from town to town, can be so different. And then also have mechanisms in place or allowances so that not only are we going to increase things like the statutory requirements, but also build up our boards of health and help them understand and bring them up with us as we do the regionalization effort.
Okay, I appreciate that. You know,
Yeah.
for the last few moments that we have in our conversation, so, you know, I work at a school, a school of public health, and we have lots of people who are going to be looking for jobs. We have lots of people who are going to be coming out of school. Excuse me. We have lots of people who are going to be coming out of school trying to think about what's the next part of their lives. You've talked about the challenges of a workforce. I'm wondering if you can make the argument for why people should consider rural settings, as well as talk a little bit about, so you've talked about some of the challenges, but I also need to hear about all the good stuff about what it means to live in a rural setting. So sell me on why I ought to come work there.
It's
I'll
so
start
hard
with an
here to live
example
out
from
here.
2 days
Go
ago
ahead.
when I went to a Board of Health meeting in one of my small towns and left just as the sun was setting. But I had to go look at a house that had a complaint about, you know, a bunch of items in the yard. And as I drove by a field, and there was 7 deer in the field grazing. And that's, I have a beautiful office when I'm driving around.
I also think that, you know, being in a rural setting, if someone who's interested in public health comes here to, like, for instance, the Berkshires, with this public health excellence grant, and the shared services, you know, they'll have an opportunity to be mentored and probably be able to increase their career a lot faster than they would be if they were working in Cambridge and working their way up from like entry-level inspector and then, you know, moderate inspector and lead inspector. You know, you get a couple of years under your belt and suddenly not only you're going to be exposed to a lot of different things, but also you too could be the health agent in your own town. And I think that the creation of full-time jobs through this public health excellence grant and hopefully the SAFE bill and whatnot will create opportunities that will be more attractive to young people or people who are new to public health coming into the field.
Yeah, I agree with what both Jane and Randy have said. I mean, I live in a beautiful area. I can walk out my door and go walk in the woods with my dogs. You know, things are, if you have a certain level of income, if you're, you know, things are so much easier here than in a city. I mean, I can get my own car. I can drive to the grocery store. I park right next to the grocery store. I put the bags back in the car. I drive and I park in my driveway and carry them. When I lived in the city, I was schlepping bags and 30-pound toddler and up my 4 flights of stairs. And it's hard to be around that many people all the time. Like, you don't realize that when you live in a city, how hard it is to be surrounded by people all the time. It's kind of nice to just, you know, my neighbors are over there somewhere. I mean, I live in a busy street, so it's not like I'm in the middle of nowhere, but, you know, so I think there's a lot of advantages to living in a rural area, and especially in the Berkshires, as much as we like to complain about the second homeowners and the tourists, they mean that there's things available here that we would never have available otherwise, the culture and so on. I think it's really hard if you're poor to live anywhere.
Mm-hmm.
And so I don't want to minimize that, but you know, the rural areas, especially in an urban state, you know, it's not like I can't be in Boston in 2 hours or New York in 3 hours. There's a lot to be said for it. It's really great.
Well, and I also think, you know, going on to what both Jane and Laura just said, you can develop a career path that's going to be quicker. And if you want to be known as a public health person, these small towns, this rural stuff can be really easier to get known because there's a lot less of you. You can get lost at a Cambridge Health Department or a Boston Health Department. You're not
also
getting
think-
lost in Berkshire County or Franklin County.
I also kind of wanted to build off of what Jane had said earlier, especially for the new grads coming into the field who don't have any, regulatory experience. Excuse me. The broadness of being in a rural community, you get exposed to everything. You might not be exposed every day, but it really develops a good foundation for a health professional to move up in their career as they go forward. And again, with the PHE grants, there are more opportunities for full-time benefited positions. And along with the training hubs coming in, they're going to have the appropriate foundation to be the next generation of public health professionals.
I think I'm going to take all of those things back to my students and see if we can encourage some people to consider, let's see about getting some more folks out there. We've got a few more moments in our conversation, and I want to turn to our experiences with COVID. Everybody has learned a lot about what we experienced with COVID. And we hope that the things that we're learning from COVID will help to prepare us for the next one that comes along. And who it's a matter of not if, but more about when. And I'm wondering if you can reflect for a moment about what have you learned that you want to make certain that we take on to the next thing that we may have to experience. And hopefully that's not too soon, but it's going to come at some point.
So I want to talk about infrastructure. We had infrastructure in Massachusetts. It's disjointed, it's inefficient and so on, but it was there and we chose not. And by we, I don't mean me. We chose not to take advantage of that. We built new parallel systems that were enormously expensive for contact tracing, for vaccinations, for a lot of things. And then they went away and they took all that income that came out of those things out of the state. And we still are in the process of building. In Berkshire County, because we're furthest away and because we already we all knew each other, it was somewhat regional. We did do some of that here in the county, particularly the vaccinations and testing through our hospital system, as well as we pretty much, I can't even remember what the contact tracing at a Partners in Health was called now, but we did most of it in-house here. Yes, thank you, Randy. And we were able to build some infrastructure. But I really see this as a huge missed opportunity across Massachusetts to have built that local infrastructure, to have taken the bones, the foundation of what was there, and to have made those systems rather than bringing in contractors and corporations from other parts of the country to do it and leaving us in the same boat we were in when we started.
And I want to just expand on that and agree with what she said. And also to point back to what we talked about earlier, one of the things we learned through COVID is, we didn't have a good experience with CTC, so we didn't use them for very long. B, what we found was we needed to do it locally because as hard as it is, the fact that I knew almost everybody I was calling, there was a huge benefit to the fact I knew everybody I was calling. And the little things that people don't think about. We delivered Horseprin to somebody who that was their biggest need. At the very early onset of COVID, one of the first people that in my hometown that got sick and passed away, talking to his wife, who at the time was called a presumed positive, her biggest need was trash stickers because it's a pay for throw bag program.
Mhm.
I was able to arrange for stickers to show up at her house. That was huge to her. CTC couldn't do those type of things.
Mhm.
We did the same on Martha's Vineyard. We reached out to volunteers. It was difficult and we did a lot of duplicative work, especially with data entry. But yes, we did not need the CTC. I understand the need for the CTC. When you have I don't know, some of these larger communities must have had 600 cases a day back in 2020. We did not have that until Omicron hit. Then we had 400 and something cases a day. But we built a team and did our own contact tracing. We also contact traced people who were not residents here. Now, of course, the state needs only to know about residents because they're responsible to report to CDC. They don't want to double report all those people from Manhattan who came flying in to sit in their second homes during the pandemic. But we traced them all. We said if they're infectious in our
did too.
communities, they're they're our responsibility. And the fact that we knew them, we used people from the Brazilian community, which is up to over a quarter of our population. We brought in and trained contact tracers so that we had not just language competence, but cultural competence. And actually, I do have to give a shout out to Biddles because their contact tracing grant has been a lifesaver for us. And I'm very determined to make that bridge from the contact tracing system or what it implies about interacting with the community during an infectious disease outbreaks, make that bridge to the public health excellence program, to better local data, understanding the local population health data, and bring it forward instead of building it up at huge expense and 18-hour days and then letting it all collapse again and back to 2019. That's my, bottom line is we do not go back on the things that we learned.
Yeah. Jane, last word.
All right, I'll be really quick. I think that the thing that we learned and will need to move forward is just communication and the importance of having local champions and understanding that there are competent people in each region that can help be the champion. And, the DPH staff is oftentimes at a disadvantage because there's I'd never realized that there was a political component to public health before the pandemic. And so, just trusting us and building those relationships, the nursing homes get regulated by DPH, but also there's portions of it that's Board of Health. We need to be able to have a mechanism to talk, automatic mechanisms for notifying each other when something's going awry. And that's what I'm really hoping our next steps will be in Massachusetts, is building the communication between local health and the state agency, and in a way that builds trust and confidence.
I'm hoping that we'll be able to take all of those things and improve our system as we move forward. Al, we have had a whirlwind tour on life in rural settings, and we have learned a lot about what it means and why we should actually all pack up and move to Sheffield. So I want to thank Jane, Camille, Laura, Marina, and Randy for helping me and helping all of us to understand about the work that they do. And I want to thank you for the work that you do now. I want to thank you for the work that you have done in the past, but perhaps most importantly, I want to thank you for all the work that you will be doing on behalf of the people in your communities and for all the people here in Massachusetts in the future. Thank you so much for participating. Al, I'm going to turn the conversation back over
Yes,
to
and
you.
I'd like to extend that gratitude from my behalf as well as the behalf of the Public Health Museum, and thank you all for such a fascinating discussion. I think there's a lot here, a lot of information here that I think is out there, but you brought it in to such a, you boiled it down and you provided such thoughtful analysis. So thank you so much. And thank you, Harold, for once again moderating our forum. And yes, thank you all. And thanks to the people attending for attending. I think this has been a really great forum.
Thank you. Thank you.
Thank
both.
you, everybody.
Thank you to everyone.
Thank you for having us. Thank
Yeah.
It
you.
was a pleasure.
And happy Public Health Week, and whatever traditions you recognize this week. It's also
Yes.
a holiday in many cultures.
Thank you.
Thank you
you.
all.
Thank
Thank
you,
you.
everybody.
Bye-bye.
Thank you.
Bye, everybody.
Nice, Al.
Yes, very good. Thank you, Harold.
Yeah.
And there was a suggestion that we actually post this online. I think I can get back to the panel and get consent for that. You know, we never put it online because we're worried about people being inhibited, but I don't think this group would have been inhibited if we were recording it for online. So
Good conversation. What
Yes,
a great
excellent. Thank
what
you.
a great panel.
yeah, I know they were wonderful. And yeah,
Yeah.
thanks.
Yeah, sure. Okay.
Take
All
care.
right. Thank you. Have a good day.